Good afternoon, everybody. Welcome to the second YUPSA webinar, Decision Making in Pediatric Colorectal Surgery. It's a collaboration between the YUPSA, Children's National in Washington, and the European Journal of Pediatric Surgery reports. We have the honor to have our friend Marc Levitt with us. He's Chief of Colorectal and Pelvic Reconstruction Surgery at the Children's National Hospital in Washington. And we have a great panel tonight consisting of Julia Brisigelli from Johannesburg, Alejandra Villanova from Madrid, and in decreasing amount of hair, it's Michael Stanton from Southampton and Jonathan Sutcliffe from Leeds. My name is Martin Lacher. I'm chairman of the education office of the YUPSA. And well, it's a great pleasure to have be among friends again. Marc, you want to say a few words? As I said, it's a pleasure to have you. Welcome to this webinar.
Thank you. I want to recognize, while she's on the screen, Gaia, who is the master organizer and the beating heart of YUPSA. I can tell you that we are all very needy for camaraderie. We miss each other a lot. We take advantage of our visits and our meetings to catch up, and we have not been able to do that. And in some small way, Gaia and the YUPSA staff has been able to keep us connected and keep us excited about clinical challenges. And I'm really very grateful for that opportunity. We are really excited about the case-based format that has been instigated by the journal that Martin edits, and I think it's a really good way to discuss a complicated case. I want you to recognize that there's no right answer to anything. We are just trying to share our experience and what we would do, and then at the end of each case, we're going to have one of the panelists do a little summary so we can learn some of the things. And I recently did a webinar, and I learned a very interesting approach, which I think we should try to employ here. And that is, there are three components. There is the learn. So what did you learn that you didn't know before? Relearn. What did you sort of know but want reaffirmed or got reaffirmed by this presentation? And then the third is unlearn. What did you think you knew and was right before, and now you've changed your mind? So if you can, in the Facebook chat, write something cool that you learned, something that you wanted to re-emphasize and now relearn, and something that you would like to now declare that you have chosen to unlearn because you learned something better to replace it. And I think we can start.
And is a 2-year-old with tuberculonic Hirshsprung disease, underwent colectomy and pull-through at the age of 10 months, and now presents after having 4 times episodes of enterocolitis in the last year. So, Marc, what do you think about this slide?
Yeah, so I mean, I think this situation is something that surgeons need to have a good thought process for, because you will have many patients that you will need to figure out if there's something wrong with the pull-through. And I think as the first step, you need to ask yourself, what was the original surgery? Obviously, if you did the pull-through, then you'll know. But if you're taking care of someone else's patient, you might not know, and you need to find out, because what was done originally will definitely affect what can go wrong. So, I mean, maybe we can ask one of the panelists. I think Jonathan has the most experience with this type of surgery. Jonathan, can you tell from this image what was the original pull-through?
Thank you, Marc. So the type of surgery we do is we often do Duhamel procedures. I can't see on the X-ray on the left down into the pelvis, and if we were to see the staple line down in the pelvis, then that would just clinch it for me. What, however, we do see on the right-hand side, where there's a lateral film, is contrast going into the rectum, and there seems to be almost two compartments of the rectum, with the catheter in the anterior compartment and then another one posteriorly connected to the pull-through. So, Marc, I'd say the most likely type of pull-through here would be a Duhamel pull-through.
Yes, and I agree. I also would have liked a picture on the left showing some more of the pelvis, but the picture on the left most notably shows that there's a bowel obstruction, and the picture on the right is the contrast study. And I will just tell you, this patient had several episodes of distension and enterocolitis, and no one got a contrast study until they asked me about the patient, and the first thing I did was I get this contrast study. Can you make a judgment? Is there something wrong with the pull-through? Is this what you would like your Duhamels to look like? Well,
Marc, the thing that I've caught here is this looks like there's a spur. And a spur is a situation where the native rectum is no longer in continuity, if you like, with the pull-through rectum. And what you get is you get an obstructive aspect to the stool coming through the pull-through rectum. And it's almost like a fundoplication, because the stool then builds up in the anterior bit and gets bigger and bigger and bigger and pushes more and more and more on the pull-through bit, and then it becomes a vicious circle. And there seem to be maybe two different times where you get a spur. One might be early, when either the surgeon hasn't adequately separated the two components of the rectal pouch. And that typically, in my experience, is when you go from the top and you don't take the native rectum down low enough to a point just above the staple line. And the other aspect of getting an early spur is when you get fusion of the staple lines. So for that reason, we would typically take the child back to theatre at about 2 weeks, or indeed just do it on the ward and put a finger in and make sure that the two staple lines haven't stuck together. And the other reason to get a spur is weeks, months, or years down the line, if the child actually gets constipation and it pushes on the anterior bit, and you sort of by default get a spur, but that doesn't really happen so often.
So this patient had total colonic Hirshsprungs. Yeah. So Alejandra, would you have done a ilioduhamel, or would you have done something different, ilioanal or J-pouch? What is your preference?
For total colonic, I would prefer to do a straight ilioanal. I don't think there is anything wrong with Duhamel, but it has been my practice in my hospital for many years. And I think it's a good option too. A straight ilioanal with a Swinson dissection type. Yes.
And Michael, what is your situation for a total colonic?
Well, in our centre, we've kind of mirrored what's happened in a lot of the UK. 20 years ago in the UK, everyone was doing Duhamels, vast majority on surveys of practice. And then with the introduction of laparoscopy, either the Swenson or the Suave has become much more popular. And that's what we've done at Southampton. We were doing Duhamels up until 10 years ago. And now I will be doing a Swenson, and a couple of my colleagues will be doing Suave type pull-throughs.
But ilioanal?
Yeah, we'd still do a Swenson or a Suave, yeah. Whatever we would do, we wouldn't do anything different because it's total colonic.
And Julia?
Hello. Same here in Johannesburg. So we would be doing a Swenson ileoanal pull-through when the child is a bit older, so around like 9 to 12 months probably, or even later than that. So when they have a bit of more solid stools.
And what about you, Martin, in Leipzig?
Well, we would do straight ileoanal too. However, I don't think the Duhamel is a bad operation. I think there's tips and tricks with like with all the other surgical techniques. So my question for the Duhamel, or for you, would be, Marc, Duhamel is like, what is the ideal length of this aganglionotic segment that you leave in place? I think that's also key.
Yeah, so if I'm asked, I would also do an ileoanal, and I would do a Swenson type. And to respond to Michael's point, I think the Suave is becoming more Swenson-like because people are making shorter and shorter cuffs. And so I would call that a Suaveson. And even for ileoanal, I think the resistance to doing an ileoanal, at least in the past, was you wanted to do something that would slow down the flow of stool. And the Duhamel was a brilliant idea to try to do that. I have to admit that I'm very biased against Duhamels, because if the Duhamel does not work, the only choice usually is to remove it. And removing of a Duhamel pouch, I think, is one of the hardest operations one needs to do in colorectal surgery. And I would much rather deal with hypermotility than hypomotility. And I'm just afraid that the Duhamel slows things down too much. However, I do acknowledge that a Duhamel done well is really, really good. And there are many patients that are doing absolutely wonderfully with their Duhamel. I would venture to say, however, that even the same surgeon, and the person who's done the most Duhamels here is Jonathan, who probably does the same Duhamel every single time, may have some patients that don't do well, and the most patients do really, really well. And I actually don't think it's a problem usually of the Duhamel. I think it's a problem of the good bowel, because not all good bowel is created equally. Some good bowel empties, no matter what, it successfully empties. We know that from the Rabine experience. How is it possible that a Rabine would ever work? Well, because the good bowel works despite the aganglionic segment. But another segment of ganglionic bowel, when put up against a dysmodal rectum, decompensates. Of course, we must rule out any technical problem, and this case illustrates exactly what Jonathan said, that there is a technical problem with this pull-through, and that's exactly what we found here, that there was a spur. And actually, very easily, through a transanal approach, we were able to palpate both the ileum and the rectum, two different lumens, and we put an endovascular staple across, and the child is doing extremely well now with that very minor intervention. Now, I know Jack Langer would advocate a laparoscopy at the same time, for fear that the small bowel may have snuck in between the two parts of the Duhamel. So just keep that in mind. Yeah, someone needs to go on mute, whoever's has some background noise. Anyway, can we see what the next slide is? I just want to be reminded. Yeah, so we went over that. Let's go to the next slide. All right, we found that, and we talked about the fix. Very good. I just want to be cognizant of the time. We want to spend about 20 minutes for each of the three cases. Does anyone have anything additional to discuss? Maybe, Jonathan, you can please give them some tips on how to make a proper pouch.
Okay, I think that there's probably three technical things that will be worth flagging up. So one is to Martin's comment about how long the pouch needs to be. The problems that I've seen you present, particularly in slideshows of referrals here, when the pouch looks like a fir tree, it's absolutely massive. And the size of the pouch we generally aim for is 1 fire of an endo-GIA, which is 6 centimeters. So actually, by the time you've got everything else in, it's about 5.5 centimeters, which means when you go around to the top and you're taking the native rectum off, you actually dissect down into the pelvic floor a little bit to do it. You're 0.5 centimeter or 1 centimeter into the pelvic floor to do it. When you open, you can actually see the staples. So that's one technical aspect. And to Martin's question, we usually aim for about 6 centimeters. I think Jack sometimes goes a little bit longer than that, but not a lot longer. And I have to say, I've not noticed problems by going a bit shorter. The other technical thing, I guess, that I've found is that when you do a Duhamel compared to a Suave or a Swenson or a Swarson, is that the size, the point where you make your incision above the dentate line needs to be a lot closer to the dentate line. So not 0.5 centimeter, 1 centimeter or 2. It's pretty much at the top of the valves. So that means that you've got to be, that's obviously because the problems that we get with Duhamel are constipation rather than the other way around. Doing that, if you take your bite too generously through the anal canal, you'll pick up sphincter behind, and that will cause pain when they start to defecate. So you've just got to be pretty careful when you put your sutures in down in the mucosa of the anal canal, but you don't go just too deep. So they're the two technical things. So, and then the third thing, as you say, if you do get a spur, you get it early, you can break it down with your finger. The ones that you'll find referred to you, Marc, are the ones like this where they're formed. I often put in a little scope, a little flexible scope when I think there's a possibility. And I do it for all of them because then I get used to knowing what normal looks like and you can visualize it very well. If you need to divide it, as you say, use an endo-GIA, I don't normally put a laparoscope in to visualize it. I've not had that problem, but I have thought about it. But I think what I'm going to start doing is putting them in a prone jackknife position to do it, because I think you get better visualization that way.
All right. Well, that was a great summary and also a great interlude, because there's actually a special section on this from YUPSA on September the 9th, where the management of total colonic Hirshsprungs is going to be discussed in great detail by Richard Wood, my good friend and partner, as well as Jonathan. So that's a little bit of an intro to a future YUPSA webinar. So let's advance the slide and show you the other YUPSA offerings. This as a teaser. So we are currently here on July the 16th, July the 29th, robotics in pediatric urology, August 26th, controversies in pediatric surgery about MEC, to drain or not to drain. September 2nd, controversies, treatment of long gap esophageal atresia. September 9th, I already mentioned. September 29th, controversies about appendicitis, conservative or operative treatment. And November 18th, controversies related to CDH and whether to patch the repair. So let's go on to the next case.